But if when we are talking about something which is safety critical, the diagnostic of a patient, where the outcome can have a profound impact on the life of a patient, we don't want to leave anything to chance. We want AI to augment, to assist, and to enhance the quality of care we provide our patients. So we're looking at a different architecture in the AI than what is prevalent today in most of the generative AI you see today, which is unsupervised. Now, unsupervised learning versus supervised learning, they're two different paradigms. Can you imagine a classroom teacher of a second grade having to chase 25,000 students alone? No, you need some supervision. Supervised learning allows us to ensure the quality of the outcome, ensure we know what we are training the system with. We also ensure whether the training set meets ethical standards, meets all the legal constraints, we haven't stolen anything from anybody, and we move along in a responsible manner to guarantee an outcome which would be able to provide the benefits we want without any of the issues they have. So there are questions about ChatGPT. In building and training these systems, who have has been part of the training set? Now there are some issues. You can see that the New York Times has filed a case against Microsoft and ChatGPT about infringement of copyright, right? So there are these ethical issues, technology is advancing too very fast. And so what I want my students, my team, the people I interact with, to ensure that what we do is responsible and to guarantee an outcome which would benefit society.
Thank you. We'll have questions at the end. We have a questions section. So yes, anyone take notes, and I'm sure there'll be some questions, hopefully, and we encourage that after we have some panel. Okay, third, here we have Dr. Doug Flora. Dr. Doug Flora serves as the Executive Medical Director of Oncology Services at the Robert Dell Sathe Endowed Chair of Oncology at St. Elizabeth. He's also the Editor-in-Chief of peer-reviewed journal AI in Precision Oncology, which is the only peer-reviewed journal, I believe. And he has over 25 years of experience in the medical field. So with so much experience in the medical field and now being having a lot of AI focus, is there an instance that got you excited about AI? Is there something that shaped you into moving forward in this world?
Yeah, it's fitting that I have a couple of my most senior mentors here who taught me to be curious. And I became curious about this about 5 or 6 years ago and started reading extensively about it and realized that it really tackled a lot of the healthcare issues that we all deal with as patients. You know, health equity is a big one. Can we democratize these technologies to make sure that you have the same chances of getting caught early with a breast cancer in Sierra Leone as we do here? You know, in our own region, about a 26-year median survival difference, maybe a mile apart between some of the more well-heeled communities and some of the less so. And I see there's a lot of opportunity in these pattern recognition devices to try and eliminate some of that and make sure that if you're seeing an oncologist in the smallest town of Paducah, Kentucky, that person has access to the same amount of information, the same clinical judgment, and number of the size and the fund of knowledge available to make the right decisions that you would get at Harvard or Boston or with Dr. Lemming at Cincinnati Cancer Advisors.
Beautiful. Yeah. And speaking of which, yeah, thanks Dr. Hawley and Lemming for being here. They are
and teaching.
Yeah, and teaching, passing along to the next generation. So yeah, let's get into it. A bit of an open panel discussion here. First, does anyone want to start with maybe some common misconceptions you see around AI in general, and just as a lot of people here, this is a whole new world for them. So I think that it's been the buzzword of the year last year, and I think there's, a lot of different stuff. John, I know we've talked a bit about this.
Well, the extremes on either side, utopic views and dystopic views of AI, I don't think are rational. I think it's better to become very educated about AI and try to be realistic. And then we can make a choice about how we use AI. We can avoid dystopic situations. We won't achieve utopia, but we can use principles of responsible and ethical AI and make better decisions and organize healthcare better. I would like to note that one of my concerns, I meet with a lot of boards, I meet with a lot of C-suite executives, and one misconception I see in chief financial officers is they believe they can cut the budget because when you invest in AI, it becomes an asset, especially if you buy an AI company. Whereas when you have human labor, that is an expense. So there are a lot of CFOs who want that AI to work and reduce, especially if they're a publicly held company on Wall Street, is putting pressure on the business to meet short-term expectations. And this is why principles of responsible AI and ethical AI are so very important in how we manage this transition. So that's one issue I'd like to bring up.
Yeah, that's something I can speak also from the creative field, especially in advertising and marketing. You know, if everyone comes to us, can we do it cheaper with AI? And especially with where it is nowadays, generally the answer is no. And usually it's more expensive with having to get inside of the tech and all of that sort of stuff, instead of just doing it the old-fashioned way.
Yeah.
But I do see that, as we've seen from Michael's beautiful presentation, we're moving forward, you know, so that's a transitionary time. And let's see. Concerns, yeah, does that opens up
I just want to follow up
Yeah,
on
please.
the rush to be able to save money. So there is this greed on the one hand, people want to make money, and on the other hand, you have immature technology. And when the two combine, it's a recipe for disaster. So there is this Manhattan law company that decided to use ChatGPT. Great, why? I can get it to paralegals, save money, give you answers right away. And they went up against a judge for a Colombian airline case where they had to come up with some precedents. And they served the judge with 6 precedents. What do you think happened? The judge, well, did his due diligence, said, do these cases ever exist? And the answer was, nope. So what happens if you lie in front of a court? Well, the judge says, first of all, they lost the case, he fined the lawyers, and then he went public and said, Judge Casket. He said, well, it's not improper to use artificial intelligence, but make sure that what you're submitting to court is accurate. And so ChatGPT says, hell, I hallucinate from time to time, don't take me seriously. But on the other hand, you know, if you decide to utilize the information coming out of ChatGPT and you use that as truth without having to validate its content, then you are responsible for it. Now, would you go to that law firm in Manhattan? Nope. You don't trust them, right? So it impacted their brand. And if I make just one more example, in saving money, Canada Air says, okay, you know, human chatbots, why do we need them? Let's use AI for that, Gen AI. And so there was this case of a person who had a bereavement in the family and went up to the website of Canada Air, got the details on how to get a refund and a lower cost for his change in flight. And after he utilized and went for the family trip, he then wanted the refund. And Canada Air said, no, there is this other obscure website where I have the rules that tell you that, you know, you were misled by our chatbot. Now, he took the chatbot to, you know, took a picture of the instructions given. He went to court, and of course he won. Why? Because Canada Air did not put in front of the chatbot, hey, from time to time I'm going to produce bullshit, don't take me seriously. Right? And so you have these cases of immature technology with greed and people wanting to make that buck, and we've got to be careful. We've got to ensure that the public does not have any harm as a result of this. Thank you.
Yeah, I don't, Dr. Flora, any thoughts? I mean, how does this, how, as patients and civilians, yeah, how do we navigate?
Yeah, I mean, I think that's the question for us, right? We can't have a single hallucination. And so there must be a human at the wheel. And we talk about augmented intelligence probably instead of artificial. And I think any of us, as we come to trust these technologies, you'll want your doctors using these because it means they're more up to date. I go back to the story, this is again a Doug Hawley thing. There were things that I thought I knew as a senior fellow at UC when I was training. And you know, you come to us because we have a broad fund of knowledge, we have hopefully a lot of clinical experience, and you choose your doctors even when you seek expert opinions because you think that they have the most clinical experience, the broadest fund of knowledge. And I was a pretty bright student or a fellow at that point, and Dr. Hawley has quoted things from the Japanese Journal of Oncology, you know, that I didn't even know existed at the time. And that sort of, it's humbling, but it also tells you that the standards of care for my practice might have changed at 3 a.m. last night based upon a paper I can't get to. There are 400 papers in PubMed indexed today to oncology that I'm responsible for learning, and that's just not feasible anymore. 144,000 articles a year indexed to oncology, and your oncologist is already working a 60-hour week trying to touch you, examine you, write notes that are onerous and heavy documentation burdens for the insurance companies that don't actually improve your care at all. And I look forward to these tools removing all of the rote mechanical stuff that you do in the creative world as well, and the stuff that I do that lets me face my patients again instead of typing on the computer when you're in the room.
Yeah, I think, yeah, and that moves us into some, we've entered some dark waters and some brighter waters. Like, how do we think we can expect to see this changing the medical field and our just experience as patients walking into our doctor's office and receiving treatment for the better, you know? Question?
What do you think government's role is?
That's a great John question. Yeah, John, how do you see the government dealing with this on a national and a worldwide scale?
The United States is unlike any other country on the earth. So our legal and regulatory system is unique in the whole world. So the European Union has passed a comprehensive AI law that is based on the principle of AI trustworthiness, explainability, robustness, resilience, accountability, privacy, and security. We have, in the United States, our US Congress is in political gridlock, so no comprehensive legislation will be passed. Therefore, the only way we can regulate at the federal level is through an executive order. An executive order theoretically lasts only during the term of the president because the next Congress can revoke them. You know, we desegregated the armed forces through an executive order, and that's still the only way we've done it. That should give you an idea. So the state of California has taken action as well. The individual states have sector-specific AI statutes as well. And so, but as a result of the way our legal system works, a lot of it is going to be done through court cases. And that's going to be expensive. And one federal circuit can have a decision that's different from another federal circuit. So my suggestion is do your very best to follow the principles of responsible AI. Use the National Institute of Standards and Technology AI risk management framework. Leverage the EU AI Act. Leverage the California Acts. Follow best principles, go above the law, so that when you face litigation, you've documented your good governance, you've documented your best efforts. You're going to be in the very best position you can be in.
And how are you seeing that on a global scale? How is China?
Well, China is just a complete, I did a lot of work in China actually, and it is a completely different world. I actually did work in China in healthcare, and so the Chinese government has some laws that the public is not allowed to read. It also has laws that the public is allowed to read. It actually does have comprehensive AI legislation. By contrast, China has a surveillance state that's very sophisticated, using facial recognition and the most sophisticated artificial intelligence algorithms. And in the healthcare context, a physician is lucky to spend 2 minutes with a patient. So they're working on a wide range of AI-empowered medical devices that a non-professional, slightly trained person in healthcare can take action to provide some sort of healthcare, particularly in rural areas. Just a completely different world.
And where, I would love to hear a perspective from everyone on the future of this. Where do you see your individual fields in 5 years, 10 years, 20 years? How do you see this being shaped by this new technology?
Responsible AI, the principles of responsible AI, they, I believe, are extremely important. So as educators, we start off there, I'm a professor at the university. A lot of our time is spent when we teach classes to students. It's all about how to do this, how to do that, how to write a program in Python, but very little about the big picture. Is understanding the ethics, responsibility. You can get a degree today in computer science or in artificial intelligence at our universities without having to ever engage in the dilemma concerning how do you responsibly use this technology, what are the guardrails you can put into place. So as president of the North American Fuzzy Information Processing Society, we are looking to present an alternative to opaqueness when it comes to, in order to be responsible, it helps if you are transparent in your decision making. You have that ability to understand clearly the entire decision making process. And when you go through that, you cannot hide behind something and say, I don't know how this happened, I'm sorry. Or sometimes you're not sorry, it happened, right? That transparency. And then the other aspect is understanding your risks. So when you're transparent, you understand the risks and you test, validate, verify, okay, then you can reach that levels of trust that we want. And you've got to be transparent, not only in your programming, but also with the public. And then you raise the awareness of our government officials. About 2 weeks ago, the Cincinnati AI Catalyst, Jamie and Michael Beck are part of, we had this presentation, AI for government operations. And the whole idea is to raise awareness of our government officials. When they went to schools from 2-3 decades ago, and in some cases 5 decades ago, they did not engage in this level of complexity, and so it's new to them. And they didn't go back to school, they don't have time. So we need to be able to present them with use cases, what is happening today, and ask the simple question. Does this meet our standard of the simple golden rule? Do you want your mother to be dragged by a car, which is self-driving car with AI, for 20 feet and say, oops, I'm sorry, AI? No, there are ways in which we need to provide that advocacy in our education, in our outreach, and in the research we conduct. And that includes having to be able to test, validate, verify, and be very open with the public as to how approach A differs from approach B, and why approach A, which is the explainable, reliable, ethical kind, makes more sense.
I may appall you guys when I tell you what's already being used. We talk about what's today. Today in clinics across the country, doctors are throwing away their laptops, and your notes are now going to be recorded in the room, and I'll come out of the room, and not only will it have the note generated for me, which I love because I can see if your daughter's getting hives, if I'm sharing too much bad news, or if the husband's starting to sweat and look pale. I think we get to embrace the art of oncology again when we give time back to these physicians. So I'm very, very enthusiastic about that. We're not ready for clinical decision support. The tools aren't wise enough yet. They're not trained enough yet to make the right decisions. They can help us, but you still want doctors making decisions. I will say where they are remarkably good is the pattern recognition I mentioned before. So in 2 years, you should not be having mammography done in a place that doesn't have a tool that augments the eyes of the mammographer. Perhaps now, that's an old Peter Drucker thing. This change has already happened. And most decision makers don't even know that these tools exist. In my healthcare system, everything we've done has been run on an AI-enabled program to do lung cancer screening CTs. We think we have the number 1 or number 2 program in the whole country now with 45,000 scans, and they're read by AI with a higher degree of alacrity and accuracy than our dedicated CT chest readers. And we know our internal data, and we know what's been published. Mammography is the same, and I'm interested to hear more about your company, not just identifying breast masses or abnormalities in architecture, but coronary artery disease risks and things like that that are, we're getting there. And the third thing I'll say is from pathology, from diagnosis. Now, there are well-published studies in dozens of different important journals, peer-reviewed journals, that have shown that an AI tool reading digitalized pixels of thousands of images of a prostate cancer or a kidney cancer like I had 6 years ago, that the tool can recognize and diagnose cancers with a greater degree of accuracy, again, than a dedicated prostate cancer pathologist at Hopkins, which is a whole different thing, again, if you're talking about a general pathologist in Paducah, Kentucky. So again, eliminating some of those disparities in care, but you have to have a human at the wheel.
Yes. And how have you, Dr. Flora, I think you might be a great person for your...
I am a great person.
Well, you're a great person, they know that.
That's all the time that we have.
But how have you seen your peers reacting to this? Obviously you seem to be fully embracing it, and yeah, through your articles that you've been peer reviewing and the peers that you've been reviewing with, has it been pretty widely accepted, or is there still...
Not at all. No, and I would say that the national studies would say the same trepidation exists in patients and doctors, because the technologies are still unsteady. And so what I did when I started the journal was I wanted peer-reviewed, really heavy scientific rigor, reviewing how things are done. And you guys, what he's not speaking to is the really hard thing, is that a lot of these tools don't know how they work. Or they do know how they work, and that's their intellectual property that differentiates themselves from their competitors. And they don't want to share that in a journal, in a materials and methods section for how they make decisions. But to speak to some of the facial recognition stuff and the equity issues, we have to see the populations that were studied. And if you have an entire population of Californians or French or people from, the lung cancer screening trial is Dutch, you may not be able to extrapolate those results to a population that's predominantly Black or Asian American that have a completely different disease process. And so we need to see the tools, how they were trained and what populations were trained and included in those data sets before we can extrapolate what we might do in the clinics to use the information that the machines deliver to us.
And how is, John, maybe you would be a good person for this, how are you seeing IP being handled?
Well, one thing I want to add, one comment before I talk about IP.
Yeah.
A trend that's already happening in all of the professions, but particularly healthcare, is what I call the deprofessionalization of the physician. The autonomy of the physician to make decisions is being decreased. That's coming through the pressure of insurance companies, Medicare, Medicaid, and the cost structure is forcing one physician to be in a supervisor position over nursing assistants. Physician assistants are seeing the same thing in anesthesia. Instead of an anesthesiologist, you have a CRNA, certified registered nurse, and that's just not necessarily a bad thing, but the entire labor and cost structure is being changed. And I want to make sure we don't want CFOs to make the decision. It's AI is good enough with less well-trained staff, non-professional staff, and you just have one professional signing off the decisions of those staff to avoid liability in a lawsuit. I don't want to see that happen. So that's one comment. Regarding intellectual property, so first of all, you are training AI almost every day of your life, whether you realize it or not. When you drive your car is sending data about your driving habits to your insurance company and to the car manufacturers. You're training the algorithms so that you can have self-driving cars in the future. You're the subject of the experiment, and you consented to it whether you know it or not. When you use your smartphone, you're training AI. You are giving data. Your email, might not be read in the sense that a human is reading it, but your email is feeding the algorithm as well. Your cell phone is tracking your location in this room and recording that data. The pattern recognition that Dr. Flora talked about is occurring right now about you, and that is feeding advertising algorithms. Privacy and intellectual property are related concepts, but they are separate. I put them in a Venn diagram, actually. And so our major intellectual property protections are copyright, trademark, patents, and trade secrets. And so here's the issue. If do I own the data in my health records? Do I have a property right in the blood or urine or tissue specimens I give the hospital? 3 court cases have said no. And once I give up that tissue sample, I have no more property interest in it. And that research facility can profit off of my tissue samples. And I have a problem with that. I think there needs to be an ethical inquiry. Now, there is a very famous case, Henrietta Lacks, and I hope you will look that up in Wikipedia. And it's a fascinating history of those cells. HE for Henrietta, LO for Locks or Lax, I can't remember which. And I think there are a lot of lessons to be learned from that. There's another trend I want to mention, and that is organoid computing. So Johns Hopkins University, business in China, and a company in Switzerland are now doing what is called biocomputing. So they are using brain cells, and they're culturing the brain cells, and they make organoids. Now, organoids have a lot of good uses in healthcare. We can research on organoids instead of the whole human being. And so now we're having what's called wetware, where there's biological material, silicon material, and software on a single chip interacting. And the advantage is brain cells learn differently from large language models based on a silicon computing model. So, and they learn faster, and they don't require as much energy. So biocomputing promises to offer much lower energy requirements, and so there's going to be a lot of investment in that as well. That is going to raise ethical issues of conducting research, and it is going to raise intellectual property issues. If you extract my brain cells and put them on a chip, do I have any property interest in that? And that's going to be interesting. That will have to be addressed through legislation. So we're really entering a new era. So efforts like what Dr. Cohen is doing, and Dr. Flora and Michael Beck, so very, very important, because we're entering this era. We do have some ethical guidance from the past. We had the Tuskegee syphilis experiments, the Nuremberg Code, and the Helsinki Declaration. So there is precedent for ethical and responsible AI that we can look to in the past, but we all need to educate ourselves as much as possible, and advocate for ourselves. So I'll just leave it there.
And Dr. Cohen, how do you see this as a high educator? Yeah, you've spoken a bit about seeing how it goes in the education system, but especially with these new, bioengineering, as we're talking about. How do you see this affecting med students moving forward in the amount that they're going to be expected to learn in their time, and how they'll be able to do that?
So one of the frontiers we need to get to is AI human. We want us to invent, as you mentioned, sir, Doug mentioned the AI would augment the behavior, the capabilities of the physician. We need to be able to train our future physicians in medical school how to establish something which is trust. Now, trust is an abstract term. We as humans clearly understand it. There are some people in our circle we trust more than others, and we have some criteria, very individual. Each one would define it differently, but it relates to our ability to trust somebody. Now, how do we establish that level of trust within the context of that specific mission? So I trust some people with certain things, like I trust my bank with certain aspects, but not with every aspect of my life. And so we need to decide, how can you trust an AI to come up with a better decision that will allow you to do your job in a better manner, right? So one example from my research is bipolar disorders. Adolescents, when they're in the manic phase, usually take some form of lithium. Now that works with about 2/3 of the cases. What do they do with the other thirds? They go to the lawyer who gives them terrific advice. Hey, if you're taking this medication and if you're allergic to it, don't take it. Right? Haven't you seen that in many ads? If you're allergic to something, don't take it. Now, so you as a patient pay the doctor, pay the doctor's lawyer for that terrific advice, pay the doctor's insurance company, pay your insurance company, and then get the side effect and end up in hospital. Right? That's the paradigm today. So in this research on bipolar disorders funded by the National Institute of Health, the premise of the medical team I worked with was that the information concerning side effects is somewhere locked in the brain. Using fMRI and MRS imaging, we can get that information out and hey, there we'll be able to solve the problem. So they had a study funded by the NIH in which they got in adolescents before they got the treatment. They had this imaging and they were subject to a test conducted by the psychiatrist called the Young Manic Rating Scale Test, YMRS. It's a figure of merit. It tells you how deep along that scale from 0 to 50 you are. Generally speaking, if you're above 20, you need medication to help you contain the symptoms, okay? And the question was, can we predict who would have an improvement with the medication and who wouldn't? So a lot of data was collected, and after 5 years of collection of data, they looked at where could we find these pins in the haystack. And the statistical tools, the biostatistics, were not good enough. So when I signed up for my sabbatical in the medical school, I was quite cocky. I said, hey, you know, my name is Kelly Cohen. I knocked on the door of the dean. I've done my bit. I'm a professor in aerospace engineering, but I know some AI. You don't have to pay me, just give me some data. And so I was given this bipolar disorder data. And we came up in a few months, and we have a peer-reviewed paper in the journal, Wiley's Journal of Bipolar Disorder, where we had 100% success in our validation. That is, after finishing the training, we could 100% success make the call as to who would have a side effect, who wouldn't. And also we were within 8% error of where your young manic rating scale is. That means if you're around 35, and the AI would say, take the medication, and we predict you're about 12, so our margin of error would be somewhere between 10 and 14. That still says, take the medication, it's gonna help you, right? Now, what we managed to do was explain how we got there. So we say, okay, there's blood flow in parts of your brain. That is the reason why you have that fMRI, and then there is a chemical composition. How do they interact in different areas of the brain to create that side effect? That is not something known by the medical field. And if we figure out what are the causes of that side effect, which patients it works with and which does not, and who it does not work with, now that's a big benefit. And that information, that additional information, is very helpful. Now we have a follow-up study with the NIH for about $10 million, together with University of Texas at Austin, to further explore and turn that into a product. Because today, while we take the imaging, we do not use that in our ability to cut down on side effects and to provide better care to our patients.
Can I tie it back to what we saw earlier? So for the broader audience, not just the healthcare nerds like us, we're gonna be looking for a different sort of medical student. You know, right now, the people that you see often are not as empathetic as you wish they were, and they're rushed, and they're not personal anymore, and it's more transactional. We've had to get students like that because we treasured the people who could learn the 15 causes of pancreatitis quickly. You know, we gave aptitude tests to say, you are bright enough to keep up with the rigor of medical school. We expect you will succeed based upon your MCAT scores and your GPA. That's not exactly who you want to see as a doctor. You want someone who can do both. In tools like this, I want to find students who are curious, who learn like your students have, how to ask the right questions. And you guys we didn't have time to get into prompt engineering, but that's what we do as doctors. I don't say, do you smoke? I say, how much do you smoke? When did you start? When did you stop? How many cigarettes a day? That's a prompt. And a really good doctor will ask better questions. That's who we really need to find in students. Same thing if she's writing music today. As a music theorist, you know that she could have typed a paragraph long prompt and said, I want you to evoke Paul McCartney melodies and why I love Yesterday or Eleanor Rigby. What is it that triggers in my amygdala that makes that song mean something that's so deep to so many people that somebody else could never have written? That's the power of the prompt, right? And so as we train these students, as we train creatives, as we train business people, as we train in law, you want to teach people to know how to speak to these tools to get the best utility out of them, and not just expect it's a one-liner. It's a skill into itself to learn how to engineer these prompts.
Yeah, and that's something I can speak on as working a lot in advertising and sonic branding and branding in general. That's one of the defining factors that brings all of the top creatives together. I'm focused in sound, and then we have the visual team, we have people writing the copy, and it's what is the prompt that's tying us all together, and seeing how we can use AI to unify the teams together is super interesting, and because it is an art in itself to be able to use these tools.
You'll see today, so I'll tag you, but my LinkedIn post was written in 15 seconds while I was taking pictures. It's already typed, it's already done. Everything that we were going to talk about before we even got up here is already in my LinkedIn post. And it gets me back 40 minutes a day that I'm supposed to be the storyteller in chief for my system, but I use it for 125 emails a day. I don't write emails anymore. My notes now, you guys will love this as you're about to see the next rollout this year for Epic. My inbox will be managed by the computer, and it will generate the letter to my patient saying, Mrs. Smith, your scans are wonderful. And it's a more empathetic answer than the doctors have time to type. I reviewed them thoroughly with the radiologist. There's no sign of cancer on your pictures. We can look forward to another scan in 3 months, and I'll come back and see you then. And that note I no longer have to type. Or I need to replace your potassium and the prescription's entered. All of these things are already in practice today, giving us back an hour or 2 or 4 a day that we can now spend getting you into the office in a shorter period of time, or spending 45 minutes with you instead of 4. And so I'm an optimist about this. I want these guys to make sure it's as safe as I believe it's going to be, but I can't wait to have them.
Yeah, and I think that's a good time we can move into some questions.